Oh, sorry for that. As importance of detecting wheezing in young children to minimize asthma exacerbation. We thanks very much Omron as we have this opportunity to be here as a sponsor meeting, and we are 3 people. We are going to present presentation on this issue. It's me, Kostas Priftis. I'm from Athens, Greece, from the National Capodistrian University of Athens. I'm going to present what is a wheezing and why it is important to confirm it is wheezing. Professor Bülent Karadağ from the University of Istanbul, Turkey, he's going to present the struggle of pediatricians and parents with a wheezing child. And the third, finally, Professor Wim van Alderen, presenting on introducing Wheeze Scan, a new tool to help parents confirm wheezing. So I'm going to present what is a wheeze and why it is important to confirm it is a wheezing sound. Noisy breathing is very well-known clinical sign. All clinicians were using it, especially pediatricians, doctors involved with children, have very high in the way of seeing people, examining people, getting history, learning very many details as they can about noisy breathing. It starts from the very early ages. Hippocrates used it, but centuries later, René Laennec, he used it, and we can see this picture as he was using auscultation, having this ear on the chest of the ill people. That's why he invented this stethoscope, and it is now 200 years from that period. Stethoscope still is the tool doctors use to listen to the chest, to check breath sounds. Breath sounds could be also through the mouth, and we could detect with naked ear. Breath sounds is, as I said, the main tool we get from the history as a symptom. So it is not easy, and we pay very much attention on that information. Laennec, from the beginning, in 1819, that it is much more difficult to describe than to distinguish breath sounds. It is really, we all clinicians, we could confirm how true was the notice Laennec wrote this time. So in my presentation, I'm going to say about breath sounds classification and then the clinical importance on the breath sounds detecting. 6 years ago, it was published a very essential paper from New England Journal of Medicine on the fundamentals of lung auscultation. It was written by Bohadana, Izviki, and Steve Craven. So they had essentially divided as normal respiratory sounds and abnormal respiratory sounds. Well, very reasonable. In normal, we have trachea sound, lung or vesicular sounds, and bronchial breathing. As abnormal, we have two groups: musical sounds and non-musical sounds, and a mixed, the one which is squawk. Stridor, wheeze, and rhoncus are musical. Fine crackle, coarse crackles, and pleural friction rub are non-musical. Our wheeze is in the group of musical respiratory sounds. 2 years later, it was another paper that came up. It was by task force of ERS as the report of this task force. First author was Hans Pasterkamp, very well known. And essentially, we followed the line very close to Bohadana paper. We have normal or basic sounds and adventitious sounds. It is lung sounds when we detect them from the chest, or respiratory sounds anywhere, detected from the mouth or the neck or from any way, or through the naked ear. And we have pleural rub, grunting, snoring, cough, all these sounds. And again, we have the classification as discontinuous and continuous. In other words, non-musical and musical. Here we have the musical breath sounds, high-pitched and low-pitched. High-pitched as wheezes and low-pitched as rhoncus, as rhonchi. Wheeze, as we said, it is a high-pitched heard with or without stethoscope, especially during expiration. It is produced by obstruction of airflow within intrathoracic airways. We can, in this way, detect asthma as an asthma sign, or can be produced by bronchiolitis, or by malacia, or by a foreign body. For so different entities producing in a different way, but pathophysiologically with the same way, wheeze. Rhoncus. Rhoncus is another type of musical continuous breath sound. We have two types of bronchus, produced by different pathology. We have low-pitched wheeze, which comes from airway wall flutter, or snoring character through secretions, as we can see here. The point is that rhoncus, it is a sound which is difficult to be recognized if it is from airway wall flutter or through air through secretions, coming through secretions. So although there are two different pathologies, they produce the same sign. And what is the clinical importance of detecting correctly the breath sounds, especially wheezing? Yes, it is. And we can see through this paper the adventure, I could say, of lung sounds, breath sounds. There were 12 experts, underline please, experts, and 2 recorded sounds. We had the possibility to divide them, to nominate them as one of them according to these prototypes. It was a mess. The experts couldn't find any agreement. The agreement was very poor, classifying the recorded sounds. Okay, then we try to have less. 4 prototypes, and we could give the name to any of the recorded sound. Well, it was fair to good. But we said finally, okay, tell me, it is crackle or wheeze, and we all had an excellent agreement. It seems that the essence of our clinical point is to confirm if it is a breath sound, crackle or wheeze. So in our case, it is quite important to be sure that it is wheeze or not wheeze. And we come back to the one stated decades ago in a paper in JAMA, saying again, classifying them as discontinuous and continuous, having these 2 types of breath sounds, and especially continuous considered as wheezing breath sounds. To be honest, in the way the task force tried to classify, to nominate breath sounds, had representatives of each language. It was again a mess, because from the same country, we have different names from the same sound. So if doctors, these were all doctors, have really difficulty to give a name, to recognize the sounds, we can understand how important it is to get the correct recognition, being as simple as we can, we doctors and patients or parents also. The take-home messages of this short presentation are the following then. 200 years after stethoscope usage, still more difficult to describe than to distinguish breath sounds, as Laennec said. Crackles and wheeze really are well recognized. Enough is enough, no more. The usage of terms varies widely, using different terms saying the same sound. An objective recognition and description would be ideal. We need the objective recognition and description then. The final assessment is a synthetic clinical procedure, as we showed, we had seen that Wheeze can be produced by different clinical entities. And that's it. The end of my presentation. And my close friend, Bülent Karadas, is going to present his own presentation. Thank you.
Thank you, Kostas, for this excellent overview of a simple term, wheezing, but how messy it is when we come to close. If you stop sharing your screen, I can start my slide screen. Kostas? I loved your screen, but okay.
Stop share, okay.
Okay, thank you very much. So now if we talk about, if we think that medicine is a kind of art, then we were talking about how can we improve our understanding of wheezing, and how can we overcome the disagreement between the families and the physicians. So we will be talking about the struggle of pediatricians and parents with a wheezing child. So the first questions are easy. Are all reported wheezing truly described by parents? Of course, no. And the second question is for us, for the pediatric pulmonologists and pediatricians, is all that wheezes asthma? Again, no. So there are two different sides of difficult and different sides of this question. So why is it important to recognize wheezing? Because if we are talking about wheezing, then we should know the benefits of the definition and treatment and prevention of wheeze. So first of all, emergency room visits. Now summer is ending, and now the season is starting. In autumn and winter, our emergency rooms will be full with wheezy child with bronchiolitis and asthma, or wheezy infant, however you call. And the second important question is for diagnosing asthma. Unfortunately, we don't have any gold standard to diagnose asthma. Wheezing is the most important tool for us, and we are in the same position with Hippocrates from the country of Kostas, and mine as well, maybe. And the third one is, in order to get appropriate medical treatment, you should diagnose wheezing. Otherwise, if you don't, especially in the developing world, if you don't call the disease as asthma, you will not be giving inhaled steroids or leukotriene antagonists to treat and to control asthma. So because of these, detecting wheezing is very important. And another aspect, another practical aspect, is frequently usage of antibiotics in these kids. Most of the kids in the emergency rooms are receiving antibiotics due to some terminology called as bronchitis, or I'm not sure whether it is pneumonia or not, that let's give antibiotic. If you cannot call the lung sound as wheeze, it is a problematic one, and most of these kids are receiving antibiotic. And again, another aspect is unnecessary lab tests. Normally, in most of the cases, you don't need any lab. You don't need to draw any blood from the kid, or you don't need to get X-ray. But if you cannot call this patient is wheezing, then this is a big problem again. And now the personalized medicine is fashionable, and in the future, I think we will be dealing with these issues much more often. So we should decrease the anxiety levels of children and the parents. So it should be a patient-focused approach. And if you can say it is wheezing, then you can assure the patients and parents that their disease is not a severe one. So this is a nice study performed in UK, and just to show the other side of wheezing. If how the patients or parents feel at home, for example, the red ones, I can understand it's difficult to read, but the red ones are the fear and anger of the families. The green ones are joy and happy memories. So when they are at home, you can see there is no happy moment because there is uncertainty. Is it wheeze? Is there any severe disease? Shall I take my child to the emergency room or so on? But even in the emergency room, pediatric board, special clinics, you can see that if the diagnosis is not clear, if the physician cannot say it is wheezing, then this fear and anger is continuing. This is an old study 20 years ago, one of the first studies showing the disagreement between the physicians and patients or parents. Because as physicians, we always think that we know everything and we diagnose. Even sometimes some physicians I know get angry about the patient. Oh, I'm the doctor, I will know this. This is totally wrong. This is proof for that. You can see here, in only 45% of the cases, parents and doctors were in agreement. So more than half parents and doctors think the other way. So in 39% of the patients you can see here, doctors found wheezing, but the parents were not calling it as wheezing. So especially when you think about the terminology used by physicians in the ERS task force organized by Kostas, even the doctors do not know how to label it. But from the parental side or patient side, it's terrible. In Turkey, still, I cannot be sure what they are calling. Just I'm trying to mimic, asking them to mimic the sound, but it's not so accurate. As you can imagine. And in 14%, you can see here, parents say there is wheeze, but the doctors say no. So it's problematic. And if you can see, look at the left-hand side to the responses to the open questions, you can see here, especially in the sound, they call it hissing, squeaking, whistle, rasp, what I hear. It's so complicated. This is another old study, but nice, because when you look at the severity of the wheezing, we can see here, if the wheezing is easily heard, the agreement is high, near 94% of the patients. If the wheezing is heard easily, also doctor found it easily. But if there is barely, you can see here, this agreement is going up. And the interesting point is the figure 2. When you look at the lung functions, peak expiratory flow rates, if you hear the wheezing easily, peak expiratory flow rate is something around 55%. If there is none, it is above 90%. So if the parents are hearing wheezing at home easily, you can just ask them direct rush into the emergency room, because maybe there will be a problem, risk for hypoxia or so on. So again, in terms of the parental understanding, ethnicity is important. This is a study, again, performed in UK among more than 4,000 patients. If the patients are South Asian, they are under-reporting wheezing. If your language is not English, again, you're under-reporting it. Again, if the mother is not giving the history, if you are not asking to the mother, again, the response is less than expected, less accurate than expected. So in most of the studies, mothers are used. So maybe when you are reading a paper about that, you should be looking at whether mothers responded it or the others. So again, socioeconomic condition affects this, mother's education affects this. If the mother is well educated, they can be have a more agreement with physicians than the others. If the mother had asthma, if the patient had recurrent wheezing, the agreement increases. So it is a benefit for the history taker to ask these and then to evaluate these to be much more accurate about the wheezing. This is another study about showing the other way. Again, the agreement is 73%, but this time parents and physician interview, wheezing and shortness of breath with parents were 20%, but the doctors found it 36%. So it's in the other direction. So according to the populations you are studying, it can differ. They can be under-reporting or over-reporting. Of course, the age of the children is important. If the parents are talking about a child at 3 years of age, the agreement between the physician and the parents are 80%. But if the child is 11 years of age, it goes up to 92%. So if the child is getting older, then the chance of being agree with the parents are getting higher. So you can see here again, and the risk of asthma also prevalence is going down with the age as expected. The first episode of wheezing is always tricky. Here you can see if the patient has fever, the patient can be reported false. The parents can report false. But if there is tachypnea and accompanying tachypnea, you can trust on the parents much more reliably. Again, it's same for the bronchi and so on. But in the end, again, parents know it best. If they report true wheeze, true positive wheeze, you can see here asthma prevalence is nearly 20%, but if there is false positive, it is 4%. So if there is an agreement between the physician and the parents, you can say that the risk of asthma is much more higher than the normal population. And again, lung functions will be lower in this correct recall group. And it's even lower than the wheezing group. Only if the only doctor hear the wheezing, it is even higher than the both-sided agreed patients. So identifying wheezing is challenging for parents, and children may not be able to, of course, we don't expect them to articulate their breathing trouble. And also there is not, experienced physicians will be agree with me, there is not only one kind of wheeze. There are different types of wheezing, even you cannot just label them. And all this noisy breathing coming from blocked nose or congestion, or even from a throat infection, can be a confusing factor, especially, for example, personally, I'm asking them, make their child to cough or just make laugh. Then if the sound disappears, it means that it is not wheezing. So what about physicians? The second part. Kostas mentioned about these and all these tables and these frequencies. Is it wheeze or rattle? What are the additional findings? Is it localized? We should be careful about foreign body aspiration. There are so many children diagnosed as asthma, but have foreign body aspiration, especially in the Mediterranean countries. And what about the risk of bronchiectasis? We should be careful about this. So the difficult side for the physicians, there are two parts. One is it really wheezing? Is there any other disease, underlying disease with this kid wheezing? So, for example, in acute bronchiolitis, it is maybe much more common than asthma. We will be hearing polyphonic wheeze and inspiratory crackles. And in acute bronchitis, due to the excessive secretions, it can be rattle. Rattle can be heard. And the same doctors can be calling these as wheezing. So it's really a difficult task. Maybe we will be needing artificial intelligence, which will be mentioned by Professor van Alderen. Acute viral bronchiolitis is another disease that we are depending on wheezing. It is the much more accurate one, accurate definition factor. If you hear wheezing on auscultation, you can call it as bronchiolitis if you are really thinking about bronchiolitis. Even there are some studies showing, is there any way to distinguish different viral infections? For example, at the A column, you are seeing influenza, and B, it's RSV. So you can see here, if you hear wheezing, the risk of this child having RSV is higher, but in influenza, there is no high risk when you look at these studies. Again, how do you call asthma? When you ask the doctors, again, wheezing is a multiple seven times higher risk for asthma diagnosis. Of course, when you see the patient, it is important. If you hear wheezing at rest or nocturnal cough, it differs. For example, wheezing at rest is the much more accurate one, as we expected. But nocturnal cough and dyspnea and wheeze is a little bit tricky. But if you look at different settings, if you are working in a medical school, again, your diagnosing asthma in a right way is much more higher than the general pediatrics practice or general practitioner. So, but when you look at the different typings, this is just, I will be focusing on the persistent troublesome wheeze subgroup. This is a latent analysis. So there is this subgroup with the yellow one. You can see here, it is the much more troublesome one. And these patients have continuous wheezing. And when you look at the age again, when the child is getting older, there is again the chance to diagnose the patient is getting higher. So in conclusion, many cultures do not have a word for wheeze. Nearly half of the parents struggle to identify wheezing sounds. Doctors fear patients will be undertreated due to the unawareness of wheezing. Wait and see approach may cause delayed intervention to prevent attacks, and physicians hesitate. They will miss any underlying diagnosis, mainly pneumonia. So take-home message for me, my lecture is, it's important to clarify the sound heard by the parents and even by doctors. We need to standardize it. Artificial intelligence may help us to overcome barriers, and Wheeze Scan seems to be the first step. Maybe we should be following Omron for the next steps. And I also, when I look at the website, I found that Omron is also well known for a good table tennis trainer. You can see here there is a robot of table tennis trainer, and just produced by Omron. And this robot is giving you scores and also showing which faults you made when you are playing. So Wheeze Scan, the world's first wheeze detection device, will help children with asthma. And last week there was a very interesting meeting or show of Elon Musk. So I think in the medical world we will be seeing this improvement so often. And my Turkish friends offered dear Elon free Turkish kebab. So maybe we will be offering free Turkish kebab to all the persons who have who helped to improve this device, and in the future who will be using this device. But in the end, even in this era of artificial intelligence, Sir William Moser is still right. Medicine is a science of uncertainty and an art of probability. Thank you for your attention. And now I will be stopping my share screen and handing over to Professor Wim van Alderen to his last but not the least session. Professor van Alderen.
Okay, Bulent, thank you very much for this very nice overview. and I'd like to continue by introducing the Wheeze Scan itself. And I'll show it to you. This is the Wheeze Scan. It's 12 centimeter long, and I will show it to you later during my presentation and show you what kind of things you can do with it. What I would like to state very clearly, it is a new tool to help parents to confirm wheeze. So it really is meant for parents and not for doctors. This is already shown by you by Costas, the stethoscope, which was invented about 200 years ago in the Necker Hospital in Paris. And what you can see about it, it's called the old warrior of medicine. And I think lots of you will agree that with me. Where I would like to start is this already somewhat older study from Fernando Martinez. And it's the title of the study is Prognosis of Early Childhood Wheeze. And what many of you know is that he started a birth cohort of about 1,000 children. And after 3 years, it appears that 1/3 of these children had wheezing during one period or more periods in their life. And he followed that group up until their age of 22, but initially to 6 years of age. And he found that of these 1/3 of the children that wheezed during their first 3 years, in 60% of the children, the wheeze disappeared again. And he called it transient wheeze. And in 40% of this group, wheeze persisted, and these children were in most cases diagnosed as asthma. Then there was the no wheeze group, and they were followed up also 6 years, and a group that never wheezed, 77%. And then a smaller group, late onset wheeze, and that was also a group where in the majority of the cases that were diagnosed as having asthma. This is a very important study, but what you have to know about it, it's very nice, but you can only use these terms in retrospect. It doesn't help you if you are in your office and you see a wheezing child in front of you, and it doesn't give a clue about the future of the wheeze of this child. And this is what we know about wheeze. 1 in 3 children wheeze before their 3rd birthday. The cumulative prevalence of wheeze at age 6 years is 50%, and it's quite an expensive disease. Preschool wheeze utilizes 0.50% of the total healthcare budget from the United Kingdom. We have a rather long differential diagnosis of preschool wheezing, and only a few of these diagnoses occur frequent. Of course, recurrent viral upper airway infections, of course, asthma, post-viral wheeze, especially post-viral wheeze after respiratory syncytial virus infection, and also wheeze that occurs in preschool children after they have been exposed to cigarette smoke. And then there is a rather long list, even longer than I put up here, long list of rare diseases. So these are the frequent ones. Then we know, and Bulland have showed it very elegantly, wheeze may be interpreted differently in the first place because of differences between observers, parents versus healthcare providers versus doctors. Wheeze can be interpreted differently when reported retrospectively versus real time or prospectively, and other factors may also play a role, such as the environmental context and the cultural context. What what for us is important is the agreement between parents and healthcare providers. And this was a study that was shown already, and this study showed that in 55% there was disagreement between parents and physician assessment of wheeze in children. And a somewhat later study from 2004 from the group from Lowy that found that lung function in children with physician-confirmed wheeze was significantly lower than lung function in children with only parental reported wheeze. And that indicates that maybe if physicians establish the diagnosis of wheeze, confirm wheeze, that means that maybe these children are worse off later in life. Another thing that we use in our daily practice is predictors for asthma. And what we know up to now is that predictors for asthma may give an indication. And we know a few. History is a predictor, especially the family history with respect to allergic diseases and asthma. Maybe physical examination, maybe if wheeze is confirmed by the doctor, that may be maybe a predictor for asthma later in life. The same holds true for non-invasive measurements such as exhaled NO, serum markers, specific IgE, certainly in relation to a history of allergic disease, is a predictor for asthma, and maybe also findings of biopsies. Predictors for asthma may differentiate between groups, but in all these cases that I mentioned, they increase the chance to develop asthma. However, there is overlap between the groups that were investigated, and up to now there is no diagnostic available for daily practice, and certainly not for parents. And what I would like to do now is step to the Wheeze Scan, the new development. And again, I'll try to show it to you again. It's 12 centimeter. Up here you can see the membrane. There is only one button on it. It has a Bluetooth receiver, and it has two indicators, wheeze, a LED light that could light up, and an indicator of no wheeze. And it detects wheeze for patients of 4 months to 12-year-old. It consists of this handset with a built-in microphone. You can place it under the right collarbone to detect, I don't know if you can see it, this is where approximately my right collarbone is. It detects a wheezing sound, and as I told you, it says wheeze or no wheeze. So it's quite a simple device. Omron Healthcare has created this unique center and the algorithm that can detect the presence of wheeze. Here you can see the different phases during the development. Breathing sounds were recorded. There is an algorithm that identifies wheeze versus other sound, and then maybe even more important, a machine learning algorithm that increases accuracy with every new data point. The development phase, lung sounds were detected, pre-processed, and put in a three-dimensional parameters spectrogram. There was a feedback loop, and the parameters were added and memorized in the algorithm. And then there is the usage phase. Again, of course, it started with the lung sounds, pre-processing, and then there was a calculation, the probability that the sound that was heard was wheeze or no wheeze. Then this in the algorithm detects abnormal sound within the red line as wheeze based upon the Corsa guideline, and all the other lung sounds were looked at whether they could be used in the wheeze spectrum or not. And the reason that it was done, that this would make it safer to detect wheeze. After this initial phase, a second phase started, and that was performed by people of the University of Medicine in Wisconsin. It was validated among children suspected to have asthma or bronchitis. And there was a comparison done between two groups, wheezing subjects and no wheezing subjects in 3 age groups, 3 months to 2 years, 3 years to 5 years, and 6 years up to and including 13 years of age. And each group contained 100 children. And this was, of course, a very important step in the validation of this device to look at the sensitivity and the specificity. And you can see here, the sensitivity is 0.95%, and the specificity is 0.90, which is really, really nice. These are the people and the hospitals in which this validation phase took place. Great job what these people did. And then I will come to my last slide. In the first place, the Wheeze Scan, which is very easy to handle. Again, here you can see what I told you before. The on-off button, the only button of the device, the indicators for wheeze or no wheeze, and the receiver and of the Bluetooth. What I have to tell you is that it does not replace the stethoscope. Stethoscope is a tool for physician, and this Wheeze Scan is a tool meant for parents. And parents shouldn't be bothered with a stethoscope. And the second thing I have to tell you is that it does not measure severity. From the physicians that use this little tool already in their clinic, an outpatient clinic, we know that the scan detects wheeze, but even if you have given a number of times a bronchodilator such as salbutamol or albuterol, it's still, if the wheezing sound is very weak, it still detects this sound. So you cannot use it to measure the severity, for instance, of an asthma attack. In the last slide that I will show you, there are apps to support this new tool. You can download them for free in the App Store if you have an iPhone, or in the Play Store if you have an Android telephone. It automatically syncs with the Wheeze Scan device, and the app is compatible with the device parents get. There is a notification function that can remind you to give the medication the doctor has prescribed. Parents can record major symptoms in the app. And of course, this is all meant to make communication with your doctor easy and more clear. Okay, thank you very much. What I would suggest is that we go to the discussion. We have a few minutes to do that. Maybe we first should, Boeland, if you can unlock your microphone. I can see that. Maybe we can start off with a few questions, and also the people that are listening can give their questions to us. I will go out my sharing point. So
we have already 2 questions. Maybe we can just start with them.
okay.
The 2 questions are from Yoba Adegoke.
Yeah.
I think 2 of them are for you. Is there a publication on the clinical validation Wheeze Scan?
No, no, that's a very good question. I think it will come, especially from the group from Wisconsin. There is no publication on the clinical validation of the Wheeze Scan, but I have no doubt that it will appear very soon.
And the second part is, if the Wheeze Scan is meant for parents, how do you mitigate the risk of a false negative result, assuming there is a severe underlying condition?
Well, I think that's also a question for me. I don't think that you cannot mitigate it, because the Wheeze Scan is a very simple device. It says wheeze or no wheeze. And of course you have to, if parents report this, that their child wheeze, you have to do a follow-up in your own office or in your own hospital. That's of course of great importance. So it is a help in diagnosing, but your responsibility as a doctor remains the same as it was yesterday. Okay, can I ask a question? Kostas,
Yes, please.
yeah, Kostas, do you think, because we are in quite a difficult discussion, parents don't know what wheeze is, maybe doctors know it a little bit better, but should we teach parents what wheeze is? I know there are video programs to teach parents, but do you think that it will be of help?
Thank you. Thank you. Yes, of course. We need it, because we need to explain what wheezing sound means. And that's the way we come back to the doctors. Doctors should be aware clearly what wheezing means. So having this possibility with the device, I come back and I could say that it is very useful, because I liked very much. It is not a machine saying we have crackles or any other bronchi or wheezing. It is just wheezing or not. As the experience says, that if we come through by saying, okay, might be a mixture of crackles, and that is mycoplasma infection or anything else, we come to a confusion. From a parent, we need just to know it is wheezing or not. It is a matter of the doctor now to differentiate through the history and the clinical examination, if it is the value. And the point is to start quite early recognizing wheezing. So especially in asthmatic children, parents mainly know what is wheezing.
And it makes it easier for you as a doctor that it's most likely wheezing what the parents describe.
Yes, of course. We never forget our medical thoughts, and we ask different questions also, other questions to organize our thought. But if we have an information that we have wheezing, we come around this thought, and we could exploit correctly the information.
Yeah, okay, that's clear. Bulent, I have a question really in line with this this question. Is there any way that we can close the gap between the understanding about wheeze between parents and physicians?
I think, thank you for this question. Also, this Wheeze Scan may help also, but I think this is only the first steps. We need time, but it's very interesting and exciting, and the start of a new era. In terms of closing this gap, I think being a good physician and giving the right decisions all depends on the time you are spending on your patients. So when you look at all this literature, it seems that if you can get a detailed history from the parents, and if you know the background, how these respondents are behaving, because we should know this, because you cannot think that a mother and father is giving the equal history to you. A mother is always giving much more emotional way. So maybe you should be asking in Turkey, for example, is it your first child? Is this the only child you have? How old were you when you get this first child? Are you a doctor, for example? All are these important questions. So I think giving enough time and taking a detailed history will help the physicians to close this gap. And also in the future, maybe I'm thinking about this Wheeze Scan Pro for the doctors, because Kostas, you worked a lot on the terminology, but in the end, again, it's messy. So
disappointing results.
Yeah. And maybe in the end, maybe we will be needing an objective way of detecting what is V's, at least also for the physician side as well. So this will be the finish of this closing the gap project. But until then, we should be getting detailed history.
So we need to know a little bit more than at this moment, and still continue to go on with what we always did.
Yeah.
Okay.
And
yeah.
Kostas, do you think that after this task force, what should ERS do? Is there anything that ERS can do, or will be something?
Oh, yes, yeah, right. The essential point is to educate doctors, and then doctors will educate their patients, their parents. So if doctors are well educated, having in their mind what wheezing is and what is behind this sign, on the other side, when we are able the snore or every other type of noisy breathing, it is so interesting to know correctly, and then we come back to clinical practice to assess correctly our patients.
But Kostas, shouldn't we try to agree on how we call wheeze? You showed, I think you did that, showed the list of all the different countries who have all different name for wheezing. In the Netherlands, we have the term piepen, which is what mice do. This is the sound mice make. That is piepen. So it's, I mean, why don't we call it all wheeze, or whatever name we want to do it? It makes, as a start, it makes it.
I'm afraid it is a waste of time to try to build a name. It comes, from the inner way, and that's the name. We need to know what does it mean. And be aware from different names. You see, in this study, we're very much surprised. The only one noise which was the same in all the languages was stridor, stridore, stridor, but only Greeks had different term, sigmos means. All the other languages, 36 languages, has the same one around stridor. So wheezing was, well, the battle was a disaster. So many terms, but still we need to know, since Sirigmos wheezing, it is the sign. We need to know correctly the sign, and then the name comes later.
Okay.
Follows.
Okay, that is reassuring. We don't have to invent a new name. I think we are coming to the end of our time, and what I like to know as a final question to Bulent, what is your approach, just your clinical approach to the first time wheeze in a child, in a young child?
Yeah, this is very tricky because when you see a child, you don't know, even this, I'm just talking about the wheezing child. Is this a bronchiolitis? Is this the first time asthma attack? Or is this another lung disease that we will be dealing on pediatric pulmonology? So it is very, very tricky. But how should we behave? I think the most important part of the answer to this question is, of course, we should be thinking about cat and dogs when we hear any noise from our garden, not the lions or tigers or giraffe. But there can be also a lion one day. You don't know. You cannot be sure. So I think, of course, we should be thinking about all the diseases, but we should behave the first time wheezer as they are having bronchiolitis, maybe, if they don't have any parental history of asthma, and if the patient does not have atopy, just wait and see protocol is appropriate for these kids. But it's very tricky and depends on the patient, and because of this, maybe individualized approach and personalized medicine will take over, and we should be listening to the parents much more often. And another important thing for a pediatric pulmonologist or pediatrician is keep the doors open to the parents. They should ask or any question whenever they want, and they can reach you whenever they want. Otherwise, it will be very tricky.
So the message is just go on with what you've always have done, and this new device can be maybe of help in the communication, but continue to think and continue to take care. Okay, well, thank you very much, Kostas.
I think there is a poll that we should be asking participants to fill in the poll. There will be a poll, and at the end, please, if all the participants can fill this poll, it will be good to improve the quality of such kind of sessions.
Okay, thank you very much. You both very much, thank you very much for your presentation and for the discussion. I would like to thank all the participants who were in this session. I think for all of us, this is new and hopefully not the future, and hopefully we will see each other live again in the coming years. Thank you very much.
Thank you.